We're going to use in our case some of the American Geriatric Society's Choosing Wisely, things clinicians and patients should question as a framework for looking at one of our patient cases. We'll also talk about some of the other pharmacy organizations that have put together medication recommendations as well for choosing wisely in that initiative. The American Medical Association has recommendations as part of steps forward for embedding pharmacists into practice and collaborating with pharmacists to improve patient outcomes. There's a module that you can complete called Embedding Pharmacists into Practice. Within that module, there are different resources. One of the resource titles is Determining Your Pharmacy Needs and Identifying the Right Type of Support. The other resource title is Quality Opportunities Checklists. There are a lot of different ideas or strategies that are included in these resources. And one of the things that is differentiated is what is the difference between having or embedding community pharmacy versus a clinical pharmacist into your practice. Depending upon the makeup of your practice and whether you have resources to have a pharmacist in the clinic with you, it can be a helpful strategy to catch any sort of questions or clarify disease state management before medications are prescribed and received by the pharmacy. This is a great resource to have if you're able to do that. Not every clinic is able to have a pharmacist right there, but you are able to still access community pharmacists and the resources that they have. So contacting your pharmacy or contacting the pharmacies where your patients are getting their medications filled can help you to be able to identify if patients are taking their medications routinely. Even asking pharmacists to go through patients' medications with them to talk about how to take them best. Pharmacists also do medication therapy management for patients, and they do complete comprehensive medication reviews for patients as they get older, ensuring they meet certain criteria. There are ways that you can work with a pharmacist in your practice to improve medication use. Pharmacists have the ability to provide immunizations. If you have patients who are unable to come to the clinic during clinic hours, pharmacists are often available for extended periods of time and can provide immunization and administration services. Pharmacists and providers can create collaborative practice agreements in the state of North Dakota, including community pharmacists working with a provider to do disease state management. Whether they are helping monitor patients' diabetes or helping to monitor patients' hypertension, these types of collaborative practice agreements can be entered into by physicians and pharmacists. There are many options for embedding pharmacists into clinical practice. The American Board of Internal Medicine has several documents they have created, which are referred to as Choosing Wisely documents. They are between 5 and 15 items, generally, of things that you should be thinking about, and that patients should be thinking about or questioning as they're looking at overall patient care in different populations. These are available for a wide variety of things. Today, we will focus primarily on looking at medication use in geriatric patients. Here are 4 different lists. The first is from the American Society of Consultant Pharmacists. This is a group that works with geriatric pharmacology or geriatric pharmacotherapy and makes recommendations. This group has a lot of pharmacists that are involved in management of patients in long-term care and assisted living facilities. The American Society of Health System Pharmacists look at pharmacy recommendations from a health system perspective from primarily the inpatient side. When examining transitions of care for patients who are coming into the hospital or patients who are being discharged from the hospital, what are some best practices that can be used to help ensure that we are improving their medication use overall? The American Geriatric Society has 10 things clinicians and patients should question. The AMDA, the Society for Post-Acute and Long-Term Care Medicine, has 15 things clinicians and patients should question. On the American Geriatric Society Choosing Wisely list, we learn to not use antipsychotics as the first choice to treat behavioral and psychological symptoms of dementia. The second point is avoid using medications other than metformin to achieve hemoglobin A1C less than 7.5% in most older adults. Moderate control is generally better, Don't use benzodiazepines or other sedative hypnotics in older adults as the first choice in insomnia, agitation, or delirium. Don't use antimicrobials to treat bacteria in older adults unless specific urinary tract symptoms are present. Don't prescribe cholinesterase inhibitors for dementia without periodic assessment for perceived cognitive benefits and adverse gastrointestinal effects. Avoid using prescription appetite stimulants or high-calorie supplements for treatment of anorexia or cachexia in older adults. Instead, optimize social supports. Avoid medications that may interfere with eating. Don't prescribe a medication without conducting a drug regimen review. This is a role for pharmacists. A pharmacist is uniquely trained to be able to conduct a medication review. It's a great area to try to incorporate pharmacists into your practice. Another form to keep in mind is the American Society of Consultant Pharmacists, who works with primarily geriatric patients. One of their first statements is, don't initiate medications to treat new or emergent symptoms without first ascertaining if a new symptom is not an adverse drug event of an already prescribed medication. A lot of adverse drug events, as patients start getting older, become more apparent. It's important for us to be thinking, as we're examining a patient, whether they're coming to pick up a medication as a pharmacist, whether they're coming in for a review, or to be seen for a new symptom as a provider to see if we can figure out if this isn't being caused by something they're already on. We also want to not continue medications at transitions of care without a pharmacist or other qualified healthcare professional performing a comprehensive medication review. One of the challenges of transitions of care is sometimes patients get discharged on medications from a similar class or same class, and then they end up with two different medications at home that are for the same thing. Having a pharmacist be mindful of reviewing the medication list and making sure that the patient and/or their caregiver understands what they should be taking is very important. Don't recommend highly anticholinergic medications in older adults without first considering safer alternatives or non-drug measures. Don't use anticholinergic medications concomitantly with cholinesterase inhibitors in patients with dementia. Don't use 2 or more medications known to increase the risk of bleeding without evaluating potential risks and benefits. Keep in mind the risk and the benefit for the patient. These medications include direct oral anticoagulants, warfarin, aspirin, selective serotonin reuptake inhibitors, antiplatelet agents, NSAIDs, and corticosteroids. This list talks about how it was created in the sources that are available, and this was also recently updated. Keeping those things in mind, we are going to use a patient case, and we're going to also take into account things like the Beers criteria to see what we might be able to identify in this case as potentially being something that we could choose more wisely in relation to how we're managing this patient's care. We have an 82-year-old female who presents to your clinic to establish care. She was last seen by a private provider 5 months ago and diagnosed with urinary incontinence stress. Today, she reports a dry mouth, occasional dizziness when she stands, and when it's been a while since she's eaten. As part of her visit today, her medications are reviewed for appropriateness. Her past medical history is listed here: hypothyroidism, hypertension, dyslipidemia, type 2 diabetes, and urinary incontinence stress 5 months ago. This is what we commonly see in the patient population. Here are her current vital signs and lab values. After reading the American Geriatric Society list and the American Society of Consultant Pharmacists, what are some things that you are thinking of? Glyburide is on the Beers criteria as not necessarily recommended to be used in older patients. It can definitely be potentially causing some of the symptoms the patient is seeing. Occasional dizziness might be hypoglycemia when she hasn't eaten in a while. Glyburide is something we can likely eliminate from this patient's medication list. Her A1C is good. Notice she's on metformin 1,000 milligrams by mouth twice daily. We don't have an eGFR for this patient, but it could be that this patient's metformin dose should be decreased too. now that she's starting to get older. She's on both naproxen and ibuprofen. She probably needs to be one of them, not both. She says she's using them as needed for headaches, but we don't really have a good understanding of what that means. It's definitely on the list of things to consider with increased risk of bleeding, along with that 81 milligrams of aspirin. The extended-release version of oxybutynin is a reason for concern, and we also don't know why she's taking omeprazole. If we look back at her complaints, she has a dry mouth. We know that oxybutynin has anticholinergic side effects, which we know can be something that we wouldn't recommend for geriatric patients. She's taking this for stress incontinence, which isn't indicated for that either. It could be that she just needs this removed from her medication list. There are some other strategies that could be used to help improve her stress incontinence as opposed to using oxybutynin. With omeprazole, it's hard to know why that was added, but that's another medication that we should look at carefully to make sure that our patient has an indication for it. Sometimes omeprazole is one that will get added during a hospital stay, and then will stay on indefinitely. Since omeprazole is available over the counter, some patients will take it because they think they need it, or that it will help. Check to make sure they're not having other reasons for why they're choosing that medication. Thinking about risk of falling and the patient. Notice her blood pressure. She meets the criteria for orthostatic hypotension based on her diastolic blood pressure. We see a change of millimeters mercury between sitting and standing. The definition of orthostatic hypertension is that it would be greater than a millimeter mercury change for diastolic blood pressure. She gets dizzy sometimes when she stands up. We might try to think about whether we should be making further adjustments based on that as well. So, maybe adjusting blood pressure medications or adjusting some of her other medications will help improve that as well. Is she slightly dehydrated? One of the things prescribers and providers noted about deprescribing was the lack of evidence or the lack of guidance. We have some guidelines for what we know for sure are harmful. We would avoid the Beers criteria, but then we don't have a really clear communicated way how to stop some of the other medications patients are taking. Notice the 81 milligrams of aspirin. There's not a lot of evidence for benefit of using 81 milligrams of aspirin as primary prevention for a patient over the age of 80. The risk of bleeding has been seen to be greater than the benefit of using aspirin. In this patient, especially with naproxen and the ibuprofen, aspirin might not be necessary. Aspirin might be one more medication that's contributing to polypharmacy for this patient. It's something to consider. With clinical practice guidelines and what's currently there, we don't have a lot of evidence to guide if or when we would ever choose to stop atorvastatin for primary prevention. This patient is 82 years old right now. They're currently doing some studies that may help us to have a better understanding of that. When you look at the clinical practice guidelines, they don't talk about patients who are over the age of 80. The primary prevention is really for a younger patient population. It doesn't mean that it's wrong for this patient to continue using atorvastatin. It's a high-intensity dose, but it's not the highest intensity dose that the patient could be on. The patient may be fine continuing to take it, but this may be one of those discussions that you have with the patient if they feel like they're taking a lot of medications. What would they like to do regarding their atorvastatin? Do they want to continue using that, or is that something that they want to discontinue? At this point, we don't have a lot of evidence that says one way or another for primary prevention. We do know that using statins for secondary prevention is important. We have a lot of guidance and information on that. For primary prevention, she has diabetes. It would be part of practice guidelines, or a standard of care, to have a statin. Understanding completely when the standard of care might change for geriatric patients for using some of these strategies for prevention would be important for us to have information on as we move forward and as our patient population continues to age. The only evidence that probably is very strong at this point in deprescribing atorvastatin for older individuals would be those who are in hospice care who have a limited life expectancy. Discontinuing a statin at that point would prove to be reasonable for those patients. With other patients, it would be your clinical judgment whether you think they would need to continue on their statin. There's nothing current that says it's harmful. Also, nothing says it's particularly helpful. We're waiting for the evidence to show us both in geriatric patients. There are lots of ways for us to improve patient care. There are clinical trials being done now in older adults to be able to determine what the best routes of treatment are for common disease states. We are seeing a lot of cardiovascular outcome trials that are happening, a lot of trials that have recognized that we have not included older adults, and so we want to try and get that information to be able to make the best decisions. With anti-diabetic agents, medications that we use, like statins, very routinely in patients, there will be more of a definitive answer as far as what the best use of these medications will be as our patients begin to age. There are many options in finding a trustworthy pharmacist. If you reach out to your local pharmacy, there may be someone who has a board certification as a pharmacist. Pharmacists now go to school for 6 years and have a PharmD degree. The last year of that training is all clinical experiences in a variety of settings. Pharmacists do a lot of looking at what the guidelines say about recommendations. They examine guideline-directed therapy, patient-specific factors of making those recommendations, where the guidelines are silent, and how they can begin to approach some of those patients. At the end of the day, the best medications to take are the ones the patients will actually take. Pharmacists try to help take those factors into play. There are a lot of pharmacists who are able to help you.